Good morning, dear students. Today's topic of our lecture, shocks. We'll talk about pathophysiology, clinical science, and intensive care. One of the latest regulatory documents on this field is Consensus on Circulatory Shock and Hemodynamic Monitoring. This consensus defines the shock as a life-threatening generalized form of acute circulatory failure associated with inadequate oxygen utilization by the cells. It's a state in which the circulation is unable to deliver sufficient oxygen to meet the demands of the tissues, resulting in cellular dysfunction. So the result is cellular dysoxia, that is, the loss of the physiological independence between oxygen delivery and oxygen consumption, associated with increased lactate levels. Some clinical symptoms suggest an impaired microcirculation, including mottled skin, atrocyanosis, slow capillary refill time, and an increased central to toid temperature gradient. Pathophysiology and the features of shock. Shock is a clinical state of acute circulatory failure that can result from one or combination of four mechanisms. The first one is decrease in venous return due to a loss of circulating volume, maybe in internal or external loss of fluids. The second is a failure of a pump function of the head that results from a loss of contractility or a major arrhythmia such as ventricular tachycardia or high-degree atrioventricular blockage. The third is the obstruction due to pulmonary embolism, tangent pneumothorax, or cardiac tamponade. And the fourth is loss of vascular tone that results in maldistribution of blood flow due to sepsis, anaphylaxis, or spinal injury. The features of each of these four types of shock often overlap, and patients admitted with one type of shock can develop other types of shock. For example, patients hospitalized with hemorrhagic shock due to trauma or with cardiogenic shock occasionally develop septic shock. Epidemiology. Up to 1/3 of patients admitted to the intensive care units are in circulatory shock, and early recognition of the condition is vital if subsequent tissue injuries to be avoided. Shock can be categorized according to the underlying cause the following way: septic shock, cardiogenic shock, anaphylactic shock, shock associated with burns, trauma, and hemorrhage. In this large trial that included more than 1,600 intensive care unit patients, septic shock was the most frequent cause of shock, accounting for 62% of cases, followed by cardiogenic shock in 17% and hypovolemia in 16%. Septic shock is the most severe manifestation of sepsis, with reported case fatality rates in the range of 40–50%, reaching as high as 80%. Limited data are available on the epidemiology of septic shock, particularly in low-income countries, but the literature suggests that its incidence is increasing. The reported incidence of septic shock in patients admitted to the intensive care units varies between 6 to 14%. Cardiogenic shock has most commonly been studied in the setting of acute myocardial infarction. The incidence in this population has remained fairly constant at between 6% and 9% over the past several decades. In a multinational observational study that included more than 65,000 patients hospitalized for an acute coronary syndrome at the beginning of the century, 4.6% developed cardiogenic shock, and the in-hospital case fatality rate was almost 60%. Pathogenesis of shock. So, the main pathogenetic process causing the shock is acute circulatory failure that results in decreased oxygen delivery to organs, decreased oxidative phosphorylation, and this can lead to energy deficit in cells, disrupting of ion channels in cell membrane, and as a result, accumulation of lactate and intracellular acidosis develop. This can result in injury of organelle functions such as mitochondria and lysosomes, so cell dysfunction and death can lead to death of the patient. Such processes take place in all organs and tissues. There is special points in gastrointestinal tract. Intestinal ischemia lead to affected barrier function of intestinal epithelium, allowing entering of microbes and toxins into the blood that provoke systemic inflammation and result in multiple organ dysfunction. Systemic inflammation may be caused by other source of infection also. Diagnosis of shock. Shock is typically associated with evidence of inadequate tissue perfusion on physical examination. And the three organs readily accessible to clinical assessment of tissue perfusion are the following. Skin. We can check degree of cutaneous perfusion. Kidneys. We can check its function by urine output. Brain function. We check using mental status examination. Also, blood pressure, heart rate, and body temperature can help us to make the proper diagnosis of shock. So, checking the hemodynamic parameters are main point in diagnosing of the shock. In this table, you can see the main parameters of hemodynamics and their normal rate. We can measure such parameters using invasive methods when you place some catheters in vein, artery, in bloodstream, and a non-invasive way. Arterial blood pressure, systolic, diastolic. In shocked patients, we often use mean arterial pressure. It's diastolic plus 1/3 of pulse pressure. Pulse pressure, it's the difference between systolic and diastolic pressure. And we can measure pressure rate in different parts of central veins, in right head camera, in pulmonary artery. For checking the pulmonary circulation, we use pulmonary wedge pressure. And central venous pressure is quite informative index in shocked patients. On the basis of measured parameters, we can calculate some integral parameters of hemodynamics. They are given in this table, such as cardiac output, stroke volume, and their indices. When you say index of cardiac output or cardiac index, it's an appropriate parameter divided to body surface area. Peripheral vascular resistance, index of peripheral vascular resistance, pulmonary vascular resistance. Also, we can calculate the amount of oxygen delivered and consumed by tissues. So, for calculation of content of oxygen in arterial blood, you can use this formula. 1 gram of hemoglobin can carry 1.34 milliliters of oxygen. So, hemoglobin multiplied to 1.34 and multiplied to saturation of hemoglobin in arterial blood with oxygen. Using this formula, but putting here saturation of venous blood, you can calculate the amount of oxygen in venous blood. And oxygen delivery, it's cardiac output multiplied to concentration of oxygen in arterial blood. Oxygen consumption, it's the difference between arterial and venous content of oxygen multiplied to cardiac output. And oxygen extraction, it's a part of delivered oxygen that catched by tissues. You can see here that oxygen consumption in stable state in healthy patient, it's about 450 milliliters per minute. It's approximately 25-30% of delivered oxygen. The presence of arterial hypotension, defined as systolic blood pressure less than 90 millimeters of mercury column or mean arterial pressure less than 65 millimeters of mercury, or rapidly decrease up to 4 millimeters of mercury from baseline, while commonly present in shock but should not be required to define of shock. Because at the beginning of shock, arterial pressure may be quite normal due to vasoconstriction. Monitoring of cardiac function. The three main reasons for monitoring cardiac function in circulatory shock are for identifying the type of shock, selecting the therapeutic intervention, and evaluating the patient's response to therapy, mainly fluid bolus. The main goal of treatment of shock is improving tissue perfusion by normalizing cardiac output. Remember that cardiac output is head rate multiplied to stroke volume. We mainly manipulate with stroke volume, but not head rate. So stroke volume is dependent on preload, on myocardial contractility, also on afterload. Afterload mainly defined by peripheral vascular resistance. Shock can be associated with 4 underlying patterns, of which 3 are associated with a low flow state. It's hypovolemic, cardiogenic, and obstructive shock, and 1 is associated with a hyperkinetic state. It's distributive shock. Shock can be due to a combination of processes. Here you can see the hemodynamic profiles in different types of shock: hypovolemic, cardiogenic, and septic. Cardiac output, it's decreased in hypovolemic and cardiogenic shock, but at the beginning of septic shock it's increased. Head rate increased, but in cardiogenic shock due to bradyarrhythmia, atrioventricular blockage, it can be decreased. Systemic vascular resistance decreased only in septic shock. In other types, it's increased, compensatory. Ejection fraction. In hypovolemic shock, it's increased, but in cardiogenic and septic shock, it's decreased. It's the ejected fraction of end diastole volume of left ventricle. Pulmonary wedge pressure. It's increased in cardiogenic shock, but decreased in hypovolemic and in septic shock. Central venous pressure has the same profile as wedge pressure. Blood pressure decreased in all types, and skin temperature only in septic shock. Cardiac index. You can see here normal ranges in green. In yellow, it's compensated state when the patient needs to be monitored tightly. In red, it's decompensated state, needing immediate intervention. And in black, it's incompatible with life. And the level of cardiac index for adult, 2.5 liters per square meter per minute, it's a shock recovery limit. Central vein catheterization at arterial line recommended in shock patients who does not respond to initial fluid resuscitation and or needs vasopressor support. Identification of the type of shock. Identifying the main mechanism responsible for shock: hypovolemic, cardiogenic, obstructive, or distributive. Distributive includes anaphylactic, septic, and neidrogenic shock. The hemodynamic assessment, such as assessing cardiac function to determine the type of shock, is needed if the clinical examination does not lead to a clear diagnosis. Echocardiography, recommended for first-line hemodynamic management in shock. It's non-invasive procedure. It's preferred modality to initially evaluate the type of shock as opposed to more invasive technologies. In complex patients, we should suggest to additional use of pulmonary artery catheterization or transpulmonary thermodilution to determine the type of shock. Transpulmonary thermodilution, it's invasive. It needs to place 2 catheters in central vein and femoral artery. Quite expensive, but quite informative. Measuring of pulmonary wedge pressure. A catheter is treated through the jugular vein in the systemic circulation through the right head and into the pulmonary artery. The wedged catheter temporarily occludes blood flow in a part of the vascular bed, and the wedge pressure is a measure of downstream pressure, which is pulmonary venous pressure. And this pressure reflects left atrial pressure, and pulmonary wedge pressure is an indicator of left ventricle preload. Pressure profiles of pulmonary and systemic circulation. Unlike the systemic circulation, the pulmonary circulation is a low pressure and low resistance system. Pulmonary circulation is characterized as normally dilated, while the systemic circulation is characterized as normally constricted. You can see here pressure profiles given in millimeters of mercury column. A bar over the number indicates mean pressure. Central venous pressure in a vena cava superior is an indicator of right ventricle preload. Perfusion markers. Plasma lactate level, mixed venous oxygen saturation or central venous oxygen saturation, and base deficit. SpO2 detects the saturation of hemoglobin in peripheral blood with oxygen. Placing the tip of catheter in vena cava superior or in pulmonary artery, we can detect venous saturation. When it's in central vein, it's called SCVO2. When it's in pulmonary artery, SVO2. Mixed blood means mixed from vena cava superior and vena cava inferior. So SCVO2 higher to 10-15% than SVO2 because vena cava inferior gives venous blood from main abdominal organs and lower part of the body, so its saturation is lower. Such catheters are used for placement for detecting, online detecting of venous saturation. This short one for central vein and the long one for pulmonary artery. This is another example. They must be connected to such monitors to have online monitoring of central venous saturation. So, saturation of venous blood with oxygen is dependent on cardiac output, on the hemoglobin rate, on the saturation of arterial blood, and on consumption of oxygen by tissues. Each of these parameters are dependent on many factors. Oxygenation state can be defined using venous blood saturation. When it's 70-80%, there is normal oxygen extraction and delivery. 50-70% decreased oxygen delivery or increased oxygen consumption, compensatory oxygen extraction. 30-50%, there is a depletion of oxygen extraction, it's beginning of lactate acidosis. 25-30% severe lactate acidosis, and less than 25% there is cell death, it's incompatible with life. When you have the patient with normal blood pressure, lactate level less than 4, normal ranges of lactate is less than 2 millimole per liter, but diagnostic measure in shock patients we use about 4 millimole per liter. So the patient with normal blood pressure, lactate less than 4 millimole per liter, but in this patient decreased venous saturation less than 70. This study we very often diagnose the shock, but it's impending shock. If in this patient with normal blood pressure, decreased venous saturation increases lactate level, it's shock, but it's latent shock. If in this patient with high lactate, low venous saturation, arterial blood pressure decreases, Very often at this stage we diagnose the shock. It's a reversible shock stage. But if in this patient with hypotension, high lactate level increases venous saturation, it's not a good thing, it's a refractory shock. The tissue cannot consume oxygen. The good situation will be when at the first normalizing blood pressure, then decreased lactate only after this increasing venous saturation. Therapeutic interventions to improve perfusion. It's fluid resuscitation using vasopressors, treatment of causing factor of shock. Inotropic agents should be added when the altered cardiac function is accompanied by a low or inadequate cardiac output and signs of tissue hypoperfusion persist after preload optimization. I think you remember two main classes of fluids, colloids with big molecular weight and crystalloids. We discussed all their advantages and negatives on the lecture on fluid electrolyte balance. But fluid resuscitation, especially in trauma patients, has its disadvantages. So in blood loss in shocked patient, infusion of fluids can dilute the rest blood in circulation system, so leading to dilutional coagulopathy. If you increase blood pressure, it push out thrombi. All these things worsen blood loss and shock state. Vital triad in shock are acidosis, hypothermia, and coagulopathy. Here you can see the Frank-Starling relationship between preload and stroke volume. When we increase preload using fluid resuscitation, in hypovolemic patients there is significant increase in stroke volume. Our target zone is this green. When the increase in stroke volume is not so significant. In hypervolemic state, giving fluids doesn't increase stroke volume. Hypovolemia as well as hypervolemia can worsen the outcome for patients. In this table, you can see the action of main vasopressors and inotropes. Receptors binding alpha-1 provide peripheral vasoconstriction, including internal organs. Beta-1 mainly inotropic effect on cardiac muscle. Beta-2 main effect is bronchodilation and maybe effect on dopamine receptors, and the hemodynamic effects on cardiac output, systemic vascular resistance, and pulmonary vascular resistance. So you can see dopamine, and there is usual infusion doses for starting. Norepinephrine, it's mainly alpha-1 effect. It has epinephrine, alpha-1, beta-1, and beta-2 effect. Phenylephrine, it's pure alpha-1 adrenomimetic. Vasopressin, it's analogous antidiuretic hormone, has some inotropic effect, special influence on splanchnic circulation. And some inotropic drugs such as dobutamine, isoproterenol, and inhibitors of phosphodiesterase 3, milrinone, enoximone, and this calcium channel sensitizer levosimendan. These drugs has positive inotropic effect, and the demand in myocardium, they increase less than dobutamine, so they are mainly used in cardiogenic shock. Traumatic shock, injury. So injury cause deaths, about 5.8 million deaths in the world per year. It's 10% of world's deaths and 32% more deaths than human insufficiency virus, tuberculosis, and malaria combined. There is trimodal distribution of trauma deaths. During the first hour, 80% of all deaths occur. So, rapid trauma care has greatest level of impact on these patients. Golden hour. War is epidemic of trauma, and the bleeding is the cause of death in half of during the first hour, and 82% of the death in operating room in trauma patients due to blood loss. The main regulatory guideline for trauma patients is Advanced Trauma Life Support, and the last 10th edition was made in 2018. This is information from ATLS, estimated blood loss based on patients' initial presentation. There are 4 classes of severity of blood loss. Class 1, volume of blood loss up to 750 mL, it's up to 15% of circulating blood volume. Class 2, 750 up to 1,500 mL, 15 to 30% of circulating blood. Class 3, 1.5 up to 2 liter, it's 30 and 40%, and more than 2 liter or more than 40%, it's class 4. And you can see the changes in hemodynamic parameters. Pulse rate increased gradually. Systolic blood pressure may be quite normal in class 1 and even in class 2 in horizontal position, but in vertical position, these patients can develop orthostatic hypotension. Pulse pressure, normal or increased in class 1, and from the class 2, it became decreased. Respiratory rate increases gradually, urine output decreases, and mental status, slightly anxious patient may be in class 1 and 2, and in severe classes may be confused or lethargic and comatose. And the last line demonstrates you initial fluid replacement. Crystalloids are recommended for class 1 and class 2, and for class 3 and 4, crystalloids and blood preparations. You can see that there is no colloids are recommended in trauma patients. Signs and symptoms of hemorrhagic biclasses, except all parameters we discussed above, you can see here base deficit. Base deficit is correlated with severity of blood loss and the need for blood products. In class 1 we can monitor, in class 2 it's possible, will be needed, in class 3 it's needed, and in class 4 you should use massive transfusion protocol. Hemodynamic response to hemorrhage in children is different from adults. You can see in this table the weight range, head rate, blood pressure, respiratory rate, and urinary output for the children, different ages. In blood loss up to 30% of circulating blood, blood pressure in children may be quite normal, then decreases rapidly. Approximately the same dynamics has cardiac output, but head rate increases up to 45% of blood loss. After this, the children develop bradycardia. Systemic responses to blood loss in pediatric patients. In blood loss up to 30%, you can see increased head rate, weak 3D peripheral pulse. Normal systolic pressure can be calculated as 80-90 plus 2 multiplied to age in years. Normal pulse pressure. The patient may be anxious, irritable, confused. The skin is cool, mottled, prolonged capillary refill time, and urine output may be low. In moderate blood loss, 30 to 45%, markedly increased head rate, weak 3D central pulse, absent pulse on periphery, low normal systolic blood pressure 70-80 plus 2 multiplied age in years, and narrowed pulse pressure. The child is lethargic, dull response to pain. This response you can check when providing central venous catheterization. The skin is maybe cyanotic, markedly prolonged capillary refill time, and urine output is minimal. In severe blood loss more than 45%, tachycardia followed by bradycardia, very weak or absent central pulses, absent peripheral pulse, hypotension less than 70 plus 2 multiplied age in years, narrowed pulse pressure or undetectable diastolic blood pressure. The patient is comatose, the skin is pale and cold, and anuria. This is a flow chart of initial management of traumatic hemorrhagic shock. The main goal in traumatic hemorrhagic shock is stop the bleeding. For this goal, it can be considered even surgical and angiographic embolization bleeding control. On one side, hemodynamic management, and on the other side, coagulation management. So, hemodynamic management, fluid resuscitation, aiming the goal level of systolic blood pressure in patients without traumatic brain injury. Systolic blood pressure you must maintain on the level from 80 up to 90 millimeters of mercury column. But in patients with traumatic brain injury, comatose, with scaled by a Glasgow Coma scale 8 and less points, systolic blood pressure must be maintained above the level 120 millimeters of mercury column. If fluid resuscitation failed to obtain goals of arterial pressure, you must suggest early administration of vasopressors. Norepinephrine is the first line. You can start with the dosage 0.1 microgram per kg per minute. And you should titrate fluids and vasopressors. In dice of preload responsiveness, cardiac output, markers of tissue oxygenation must be defined. Coagulation management. Tranexamic acid, its inhibitor of fibrinolysis, must be started at pre-hospital level. 1 gram, then repeating this dose every 8 hours before stopping bleeding. And transfusion coagulation targets. In patients without traumatic brain injury, it's enough hemoglobin level 70-90 gram per liter. But in patients with traumatic brain injury in comatose state, the aimed hemoglobin level is more than 100 gram per liter. Prothrombin time, activated partial thromboplastin time, must be less than 1.5 folds from normal in both categories. Platelets. For patients without traumatic brain injury, it's enough 50, but with comatose brain injury, platelets must be kept more than 100. Fibrinogen, 1.5 2 grams per liter aimed level. And you should prevent acidosis, keep normothermia, and control the level of ionized calcium. It must be kept on the level 1.1, 1.3 millimole per liter. The main pathophysiological mechanisms involved in acute traumatic coagulopathy and transfusion strategy. So, traumatic hemorrhagic shock, tissue injury, shock per se, provide inflammation, excessive activation of the coagulation factors, and fibrinolysis. Fluid resuscitation can lead to hemodilution, hypothermia, hypocalcemia, tissue hypoxia, acidosis, anemia. All these things decrease activity of coagulation factors and the platelet function. And all these mechanisms responsible for acute traumatic coagulopathy. You should provide bedside coagulation monitoring. We said about tranexamic acid, low volume resuscitation, systolic blood pressure keeping at 80-90 when the patient without traumatic brain injury, early administration of vasopressors, normothermia, normal level of ionized calcium. You should avoid delays in the delivery, massive transfusion protocol in severe hemorrhage. Red blood cells, fresh fluid plasma ratio must be less than 2:1. Early administration of fresh fluid plasma and fibrinogen level more than 2 grams per liter will help to treat this traumatic coagulopathy. Fluid resuscitation. ATLS recommends 1 liter of crystalloids in adult, 20 milliliters per kg for children with body mass less than 40 kg. This volume includes pre-hospitally infused fluid. After this volume administered, we should check the patient's response to volume resuscitation. We should balance between organ perfusion and the risk of increased hemorrhage. And this strategy has main names such as controlled resuscitation, balanced hypotensive resuscitation, permissive hypotension, but such permissive hypotension must not last longer than 1 hour. It can lead to ischemia in organs. Responses to initial fluid resuscitation, how to check it. There may be 3 variants of response: rapid response, transient response, and minimal or no response. Vital signs in rapid response: return to normal. Estimated blood loss may be less than 15% of circulating blood volume. There is low need for blood preparations, but blood preparations might be type and cross-match checked. Need for operative intervention possibly, and early presence of surgeon is needed. Transient response. Transient improvement, recurrence of decreased blood pressure and increased heart rate. The volume of blood loss in this case may be moderate or ongoing from 15 to 40%. Need for blood moderate to high. The blood must be type specific, and need for surgery likely, and surgeon is needed. Minimal or no response. If after fluid bolus vital signs remain abnormal, in these cases blood loss may be severe, more than 40%, and there is immediate need for blood preparations and emergency blood release, and highly likely needed surgery, operative intervention, and surgeon is needed. Checking the patient's response to volume resuscitation, check organ perfusion, consciousness, capillary refill time, urine output. Minimum must be for adult 0.5 ml per kg per hour, for children 1 milliliters per kg, and for infants for up to 1 year 2 milliliters per kg. And you can check urine specific gravity and laboratory tests dynamics of base excess, base deficit, and lactate. Massive transfusions. When more than 10 doses of packed red blood cells per 24-hour used, or 4 doses per hour. Early administration of packed red blood cells, fresh fluid plasma, and platelets. And you should limit aggressive crystalloid therapy and warm fluids up to 39 centigrade. Early surgical or endovascular control of hemorrhage are very important points in patients with severe blood loss, more than 40% of circulating blood. You can use autotransfusion using cell savers, especially in hemothorax. You should calcium administration and treat or avoid acidosis and hypothermia. Septic shock. Main regulatory guidelines made by Surviving Sepsis campaign. Last reduction from 2016. This is the latest evidence for treating the sepsis. In green, you can see actual points, and in red, the points of administration, the points of management of the patient that has not demonstrated efficacy. Pathogenesis of septic shock. Bacterial endotoxins, it's mainly lipopolysaccharides, provoke systemic inflammatory syndrome, damaging cell membranes, glycocalyx in capillary endothelium, leading to capillary leakage syndrome, and this results in fluid loss from circulation into interstitial and intracellular spaces. So it affected blood viscosity, lead to hypovolemia and organ perfusion and in shock state. There is cytokine storm in sepsis. Main cytokines provoke damage of multiple organs. In shock states, hemodynamic instability results from many factors. One of them is increased venous capacitance or decreased arterial resistance. All inflammatory markers provide vasodilation system, so it decreases venous return to the head. Inflammatory mediators provide increased pulmonary vascular resistance, decreasing the preload of left ventricle. Such mediators can damage myocardium, so increasing ventricular compliance and decreasing contractility. And on the capillary level, they damage glycocalyx, leading to capillary leakage. So there are many causing points for hemodynamic destabilization and septic shock. The capillary escape rate of albumin, normally it's 4-5% of its content in blood per hour. But in the same rate, albumin returns with lymph into vein. But in patients with affected glycocalyx and capillary leakage, the transcapillary escape rate of albumin increases 3-5 times. But returning rate cannot be increased. So in this case, albumin is depositing in interstitial space, accumulating there water and providing severe edema. Definitions. Sepsis Surviving Campaign provide next definitions for sepsis and septic shock. Sepsis, life-threatening organ dysfunction caused by dysregulated host response to infection. And septic shock, subset of sepsis with circulatory and cellular metabolic dysfunction associated with higher risk of mortality. How to identify acute organ dysfunction as a marker of severe sepsis? For brain function, it's altered consciousness, confusion, psychosis. For respiratory system, it's partial pressure of oxygen in blood less than 70 millimeters of mercury, saturation of arterial blood less than 90%, and oxygenation index when dividing partial pressure of oxygen to fractional concentration of oxygen in inspired air when it's less than 300. This is the signs of respiratory dysfunction. Liver function, jaundice, increased enzymes, decreased albumin, and increased prothrombin time. Cardiovascular system, tachycardia, hypotension, increased central venous pressure, pulmonary wedge pressure. Kidney functions, oliguria, anuria, and increased creatinine. And bone function, decreased platelets, increased prothrombin time, activated partial thromboplastin time, increased protein C, or decreased D-dimers. Clinical assessment of organ dysfunction in sepsis. More than 2 points, according to SOFA scale, indicate sepsis-related organ dysfunction. This increases mortality to 10%. This is a sequential organ failure assessment score, SOFA score, provided by Dr. Jean-Louis Vincent. It's very big authority in intensive care. It's head of the European Society of Intensive Care Medicine. You can see in SOFA score, some parameters are scored from 0 to 4 points. It's respiratory, cardiovascular, mean arterial pressure or need in vasopressors, liver function by bilirubin level, creatinine level for renal function, platelets for coagulation, and neurologic state using Glasgow Coma scale. Sepsis 3 also derived a bedside assessment tool for sepsis screening in patients with infection who are not in intensive care units. Called the Quick-SOFA score, it includes 1 point for each of three criteria: respiratory rate more than 22 per minute, altered mental status, and systolic blood pressure less than 100 millimeters of mercury column. A Quick-SOFA score 2 and more is suggestive of sepsis. Sepsis 3 recommends that for a Quick-SOFA score less than 2, the full SOFA score, including laboratory results, should be used. Septic shock. Identification of the patients in septic shock. It's vasopressor need for maintaining mean arterial pressure above the level 65 millimeters of mercury column, lactate level more than 4 millimole per liter in absence of hypovolemia. The combination of these two associated with mortality more than 40%. Sepsis and septic shock are medical emergencies, and these guidelines recommend that treatment and resuscitation must be begin immediately. These guidelines recommend that a specific anatomic diagnosis of infection requiring emergent source control be identified or excluded as rapidly as possible in patients with sepsis or septic shock, and that any required source control intervention be implemented as soon as medically or logistically practical after the diagnosis is made. Guidelines recommend that administration of intravenous antimicrobials be initiated as soon as possible after recognition and within 1 hour for both sepsis and septic shock. And it's recommended empiric broad spectrum therapy with one or more antimicrobials to cover all likely pathogens. Initial resuscitation. Guidelines recommend that in the resuscitation from sepsis-induced hypoperfusion, at least 30 milliliters per kg of intravenous crystalloid fluid be given within the first 3 hours. And it's recommended that following initial fluid resuscitation, additional fluids be guided by a frequent reassessment of hemodynamic status. It's recommended crystalloids as the fluid of choice for initial resuscitation and subsequent intravascular volume replacement in patients with sepsis and septic shock. It's suggested using albumin in addition to crystalloids when patients require substantial amounts of crystalloids. This is application of fluid resuscitation in adult septic shock. So, when sepsis-induced hypotension, needing vasopressor support, and lactate level more than 4 millimole per liter, in patients without end-stage renal disease on dialysis, without congestive heart failure, patient not needing high-flow oxygen, you can provide a rapid infusion of 30 milliliters per kg crystalloids. In patients with end-stage renal disease on hemodialysis or congestive heart failure, the same amount, 30 milliliters per kg, must be infused with frequent reassessment of oxygenation. If the patient has pneumonia or acute lung injury with high flow oxygen requirements, if the patient is not intubated, you must consider intubation and providing mechanical ventilation. After the intubated, in intubated patients, a rapid infusion of such volume, 30 ml per kg of crystalloids, is administered. And total volume 30 milliliters per kg with frequent reassessment of oxygenation in patients that cannot be intubated. And considerations after administering 30 ml per kg. We should continue to balance fluid resuscitation and vasopressor dose with attention on maintaining tissue perfusion and minimizing interstitial edema. Implement some combination of the list below to aid in further resuscitation choices that may include additional fluid or inotropic therapy, blood pressure, heart rate response, urine output, cardiothoracic ultrasound, central venous pressure, central venous saturation, pulse pressure variation, lactate clearance or normalizing, dynamic measurements such as response of flow to fluid bolus or passive leg rising, and consider albumin fluid resuscitation when large volumes of crystalloids are required to maintain intravascular volume. This is a summarizing sepsis 3 guidelines. Said about definitions, these guidelines de-emphasize severe sepsis and sepsis criteria. Fluids during the 3-hour 30 ml per kg in all patients is considered. Vasopressors we'll discuss in details. Steroids. No steroids are recommended unless shock refractory to adequate fluids and vasopressors. Antibiotics, broad spectrum, avoid double coverage. Fact red blood cells. The goal level of hemoglobin may be 70 grams per liter. Source control as soon as feasible. In old guidelines, it was within 12 hours. And the ventilation parameters, it's called lung protective ventilation with tidal volume 6 ml per kg of ideal body weight, with plateau pressure less than 30 centimeters of water column. Role of BiPAP is unknown. And goal therapy, targeting at mean arterial pressure 65 millimeters of mercury and normalization of lactate. Prefer dynamic variables to assess fluid responsiveness that emphasize protocolized KS, CVP, and central venous saturation. Vasopressors in septic shock. We should start with norepinephrine at this dosage, aiming mean arterial pressure 65 millimeters of mercury column. If it's not achieved, you can add vasopressin. At this stage, you can consider using corticosteroids. If norepinephrine vasopressin cannot achieve the goal level of mean arterial pressure, the next medicament is epinephrine. At this stage, you should administer corticosteroids. If all these things fail to achieve mean arterial pressure 65 millimeters of mercury, you can consider phenylephrine until reaching goal level of MAP. Dopamine is recommended only in bradycardia. It's a pulmonary artery catheter-guided treatment protocol by Jean-Louis Vincent. So resuscitate to a mean arterial pressure of 65 millimeters of mercury column. You can check for missed venous blood saturation. If it's normal, maybe Jean-Louis Vincent says do nothing. When it's low, we should check on arterial saturation. If there is low arterial saturation, you must provide oxygen therapy, increase the parameters of ventilation. If arterial saturation is normal but venous saturation is low, you should check for cardiac output. In low cardiac output, you should check pulmonary wedge pressure. If it's normal, it's hypovolemia, the patient needs fluid challenge. If wedge pressure high, it's a decreased myocardial contractility, so the patient needs inotropic support with dobutamine. If cardiac output is high, normal, you should check for hemoglobin. Less than 80 grams per liter, the patient needs blood transfusion. More than 80, it may be increased consumption of oxygen due to stress, anxiety, and pain, the patient needs appropriate treatment. In pain, he needs analgesia. In anxiety, maybe sedation. Cardiogenic shock. Causing factors: low cardiac output due to decreased myocardial contractility, valve defect, pharmacology, toxic depression of myocardium, obstruction with tumor, tension pneumothorax, cardiac tamponade. Hemodynamic parameter we discussed above. Clinical signs: the patient may be pale or cyanotic, prolonged capillary refill time, dilated neck veins, increasing pulmonary edema, precipitating sounds in lungs. In chronic cardiac failure, you can see hepatomegaly, splenomegaly, ascites, pleural effusion, and anasarca. Treatment of cardiogenic shock depends on causing factors. In acute myocardial infarction, it's coronary artery reperfusion using thrombolytics or stenting of coronary artery. In thromboembolism of pulmonary artery, the patient needs thrombolytics. In severe arrhythmias, antiarrhythmic drugs. In case of damage of valves and papillary muscles, cardiac aortic obstructions, the patient needs surgical correction. Increasing cardiac output. You should use dobutamine, maybe in some cases dopamine, nitroglycerin, inhibitors of phosphodiesterase such as amrinone, milrinone. Restricting fluid volume under the control of pulmonary capillary closing pressure, maintaining it at the level 12-15 millimeters of mercury. If it's above 18 millimeters of mercury, you should use diuretics. Oxygen inhalation, artificial ventilation, if spontaneous respiration is inadequate. This is recommendations for treatment of myocardial infarction complicated with left ventricular failure according to cardiac index rates and pulmonary capillary closing pressure. This is a recommendation for management of patients with left ventricular shock algorithm. In severe cases, when all medicaments failed to treat such state, it can be considered intra-aortic balloon compression, left ventricular assisting device, and extracorporeal membrane oxygenation. And this protocols, the recommendations for treatment of patients with right ventricular shock. Neurogenic shock. It's distributive shock due to affected sympathetic innervations, which leads to redistribution of blood into dilated vessels in affected area. It can be caused by spinal trauma, upper thoracic cervical level of spinal cord or brainstem, maybe due to drug effect on vasomotor centers such as anesthetics, antidepressants, hypnotics. Acute hypoglycemia can lead to neurogenic shock and neuroaxial anesthesia when high level spinal or epidural. Clinical signs. Systemic vascular resistance decreased in affected area but increased in intact area. Cardiac output decreased due to decreased preload. Pulmonary capillary closing pressure decreased. Central venous pressure decreased. Decreased blood pressure and tachycardia. Urine output may be normal at the beginning, but then it decreases. Skin is warm in denervated area, but cool in intact area. Clinical manifestation of underlying disease present in neurogenic shock. Management of neurogenic shock. Fluid therapy, mainly crystalloids. In severe hypotension may be considered colloids. Vasopressors, preferable alpha-1 agonists. Steroids in spinal trauma and artificial ventilation if needed. The clinical signs of spinal trauma with the spinal cord damage or compression. Pain in vertebral column, impossibility of voluntary movements of extremities, often in legs, but in spinal trauma in upper cervical level, it can be present in arms too. Anesthesia below the level of spinal damage, urinary and fecal incontinence, difficult to diagnose in – 'unconscious' patients in brain trauma or alcohol coma. 'Brain trauma' 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 Urgent management in spinal trauma. Adequate ventilation and oxygenation, hemodynamic stabilization for adequate perfusion, immobilization of vertebral column to prevent additional spinal cord damage, and urgent spinal cord decompression in cases of compression by fractured vertebra. There is a relationship between the level of spinal cord damage and respiratory dysfunction. Higher level of damage, the patient likely needs artificial ventilation due to decreased vital lung volume and ineffective cough reflex. Hemodynamic instability in spinal trauma. Denervation due to spinal trauma leads to autonomic nervous system dysfunction in the affected area. This results to vasodilation, bradycardia, hypotension, and hypothermia. Hypotension is usually absent in spinal trauma below the level of thoracic 6. If it's present in such cases, you should suspect internal bleeding, and hemoglobin and hematocrit should be done 2-4 times during the first day after the spinal trauma. Infusion therapy in spinal trauma. In severe hypotension with systolic blood pressure less than 60 millimeters of mercury, we should start with hypertonic sodium chloride 7.5% in rate 4-6 mL per kg. Maybe colloids can be considered in severe hypotension. And after the correction of hypovolemia, you can reset to normal saline. And total volume 2.5-3 liters can be infused during the first day. This scheme is recommended for adequate perfusion in affected zone and prevention of ascending spinal cord edema. In relatively stable hemodynamic parameters with systemic blood pressure above the level 80 millimeters of mercury, you can infuse only isotonic saline solutions. If the infusion rate cannot provide the hemodynamic stabilization, blood pressure more than 100 millimeters of mercury, we should use vasopressors. First line vasopressor may be norepinephrine, phenylephrine. For increasing blood pressure systolic up to 130 millimeters of mercury. If the bleeding is excluded, the infusion volume should not exceed 3 liters per day. In patients with spinal trauma, large infusion volumes can result in pulmonary edema. For prevention of ascending spinal cord edema, methylprednisolone is recommended in dosage 30 mg per kg starting at pre-hospital stage. And corticosteroids are contraindicated in patients with infection and gastric ulcers. Nursing and nutrition in spinal trauma very important. Prevention of bed sores, mattress for preventing pressure sources, some physical exercises, changing the pose of patient, enteral nutrition in unconscious patients. Tube feeding after the excluding intestinal paresis must be started in the first days. Deep vein thrombosis prophylaxis using heparin, antibiotics, and gastric stress ulcer prophylaxis using ion pump inhibitors or H2 histamine blockers. Burn shock due to plasma loss through the burned area. I think you remember structure of skin. There is 3 main layers: epidermis, dermis, and hypodermis. There is Jackson's burn zones. In the center of burn zones, there is zone of coagulation. Around this zone, there is a zone of stasis, and external region, it's zone of hyperemia. If you provide adequate resuscitation, we can preserve the zone of stasis, but in the zone of coagulation, there is necrotic tissue. If resuscitation is inadequate, you can lose stasis zone and it became necrotic. This is a classification of burns according to the depth, appearance, sensation, and outcomes. Superficial burns, first degree, confined to epidermis, appearances dry and red, blanches. It's quite painful and heals spontaneously. Partial sickness, second degree, superficial dermal burns. Epidermis and upper dermis is damaged. There is blisters, moist, red, and weeping blanches. Painful to air and temperature. It can heal spontaneously. Second degree deep dermal burns. Affected epidermis and deep dermis. There is blisters, wet or waxy dry, patchy to cheese, white, red, does not blanch. Sensation to pressure only. There is no pain due to loss of peripheral sensory receptors. It requires excision and grafting for return of function. Full sickness, third degree burns, damage. It's destruction of epidermis and dermis. Appearance waxy white, lacery gray or charred and black, dry and inelastic, does not blanch. There is sensation to deep pressure only and requires complete excision and limited function due to contractions. Fourth degree burns affect underlying tissues such as muscles, fascia, and bone. Sensation to deep pressure only and requires excision and grafting and limited function due to formation of contracture. You can see here first degree burns, second degree, and third degree burns. On the patient, it can look like this. And the management of first degree burns include cooling with warm water over the area of burn and covering the burn with a sterile bandage. Second degree superficial burns. Blisters are characteristic for this degree and deep second degree burns. And the patient management in second degree burns include airway protection, wet sterile dressing on wound, ointments with silver inhibiting the growth of bacteria, remove jewelry and tight clothing that does not stick to the skin. Intravenous fluids are needed, oxygen therapy if necessary, assess possible signs of shock, and provide analgesia mainly, opioids, wound cleaning, removal of dead tissue, and skin graft may be needed. Third degree burns look like this, and on the healing there will be contractures. And fourth degree burns affect underlying tissues. Estimation of burn surface area. Mainly it's used ninth rule. This one is for adults, ninth rule, chart for childs and for infants. The patient can develop burns to the airway, can cause swelling that blocks the flow of air into the lungs. And severe inhalation injury may be due to chemical or smoke exposure. Fluid therapy in burn shock. There are several rules can be used for calculation of volume of infusion for first day and for subsequent days, and mainly crystalloid solutions are recommended. There's Parkland's rule and Evans' rule. Anaphylactic shock. It's severe allergic reaction with generalized vasodilation due to anaphylactic factors such as histamine, bradykinin, interleukins, etc. Causing factors of anaphylactic shock, it's mainly insect and snake biting in 77% of cases. May be caused by vaccines, blood components, hemoglobulins, may be caused due to administration of medicaments, and very rare Anaphylactic shock occurs in food allergy. This is the causing factors in medical practice and mechanisms of development of anaphylaxis. You can see many medicaments, antibiotics, such things as latex, X-rays, plasma components, and others. This is the recommendations of European Resuscitation Council for the management of patients with anaphylactic reaction. For diagnosing, you should for acute onset of illness, life-threatening airway or breathing and circulation problems, and usually skin changes are present. And medicaments must be used. It's adrenaline, the first line. There is you can check for life-threatening problems in anaphylaxis, such as swelling, airway swelling, hoarseness, stridor, rapid breathing, wheezing, fatigue, cyanosis, saturation decrease less than 92%, confusion, circulation problems, pale skin, clammy, low blood pressure, faintness, drowsy, and comatose state. In the presence of any of these life-threatening problems, you should start with intramuscular injection of adrenaline, 0.5 ml in adults, and there is dosage for children. And there is information that sounds adrenaline intravenously to be given only by experienced specialists. These are mainly anesthesiologists and emergency medicine specialists. You should give in such patients fluids intravenously, half up to 1 liter crystalloids in adults and 20 ml per kg in children. And also recommended intramuscular or intravenous administration of chlorphenamine and hydrocortisone. Thank you for your attention.